Podcast 12 of the Upper Limb series. The joints of the upper limb. This podcast is going to focus on the joints of the upper limb and detail the anatomy of the shoulder, the elbow and the wrist. I will also detail the dislocations that can occur at these joints. So let's start with the shoulder or the glenohumeral joint. The glenohumeral joint is a ball and socket type of synovial joint which has a wide range of movements. However, because of its wide range of movements, it is also a relatively unstable joint. The articulations of the glenohumeral joint are between the shallow glenoid cavity of the scapula and the large rounded humeral head of the humerus. Both of these articulating surfaces are covered by hyaline cartilage. The glenoid cavity of the scapula is further deepened by the glenoid labrum. This tough ring of cartilage runs around the edge of the glenoid cavity to increase the bony congruity of the joint and also deepen the glenoid cavity so that approximately a third of the humeral head is covered. Like all synovial joints, the glenohumeral joint is comprised of an outer fibrous layer and an inner synovial layer. The glenohumeral joint's fibrous layer is relatively loose but has a series of ligaments that reinforces the joint. There is the glenohumeral ligament anteriorly and the coracohumeral ligament superiorly. The glenohumeral ligament is comprised of three bands that extend from the glenoid labrum at the supraglenoid tubercle to the anatomical neck of the humerus, and this ligament serves to reinforce the anterior aspect of the joint capsule. Superiorly, the coracohumeral ligament extends from the coracoid process of the scapula to the greater tubercle of the humerus, and this ligament serves to reinforce the superior aspect of the joint capsule. As these are thickenings of the joint capsule, both the glenohumeral ligament and the coracohumeral ligament are considered intrinsic ligaments. Further supporting the glenohumeral joint superiorly is the coracoacromial arch. This is a protective structure formed by the coracoacromial ligament, and this extends between the acromion and the coracoid process of the scapula. This ligament serves to prevent superior displacement of the humeral head. As this ligament is not part of the joint capsule, it is considered an extrinsic ligament. Alongside the fibrous capsule and supporting ligaments of the glenohumeral joint, there is also the rotator cuff muscles that I detailed in podcast 2. These are supraspinatus, infraspinatus, teres minor and subscapularis, and these add further support to the joint by clamping the humeral head against the glenoid cavity. So in summary, the large humeral head and the small glenoid cavity, alongside the loose, flexible joint capsule, allows the glenohumeral joint to undergo a wide range of movements, including extension, flexion, adduction, abduction, medial and lateral rotation, and combining these movements, circumduction. However, because of the shoulder joint's wide range of movements and relative instability, it is commonly dislocated. The most common direction of a glenohumeral dislocation is downwards or inferiorly. This is common when the humerus is fully abducted, and a direct blow to the humerus can drive the humeral head inferiorly towards the weaker inferior part of the joint capsule. This would force the humeral head to be positioned inferior to the infraglenoid tubercle, and due to the attachment of pectoralis major, which is on the shaft of the humerus head is pulled anteriorly and is positioned between the anterior auxiliary fold and the clavicle. A superior dislocation is rarer than an inferior dislocation because both the rotator cuff muscles and the coracoacromial arch prevent the humeral head being forced superiorly. So now let's turn to the elbow joint. The elbow joint is a hinge joint between the humerus, the ulna and the radius. It is crossed by a staggering 17 individual muscles which enable the elbow to undergo extension and flexion. Also associated with the elbow is the proximal radio-ulnar joint, and I'll come to that in a moment, But first let's detail the elbow joint itself. The articulation sites of the elbow joint are between the trochlear of the humerus and the trochlear notch of the ulna, and also the capitulum of the humerus and the head of the radius. Again, this joint is covered by a fibrous joint capsule that is lined by a synovial membrane. The joint capsule is reinforced by thickenings which form two collateral ligaments, the radial and ulnar collateral ligaments. The ulnar collateral ligament is triangular shaped and extends on the medial aspect of the elbow from the medial epicondyle of the humerus to the coronoid process and olecranon of the ulna. The radial collateral ligament is fan-shaped and smaller than the ulnar collateral ligament, and this extends on the lateral aspects of the elbow from the lateral epicondyle to the annular ligament which surrounds the head of the radius. The annular ligament is important in supination and pronation of the forearm, and I'll detail this in a moment. So before I go on to the proximal radio-ulnar joint, I just want to mention the carrying angle. In the anatomical position, with the elbow fully extended and the palm facing forwards, the upper limb does not form a straight line due to the ulna deviating laterally. This is known as the carrying angle. In the male, the carrying angle is about 10 degrees, whilst in females there is a slightly greater deviation of about 15 degrees. It is thought that this increased angle allows the elbow to clear the wider pelvis of the female when walking. Okay, so now let's turn to the proximal radio-ulnar joint. This joint is slightly distal to the elbow joint and allows the forearm to undergo supination and pronation. It allows the head of the radius to articulate with the radial notch of the ulna and is held in position by the annular ligament. So the annular ligament is a C-shaped ligament that attaches to the anterior and posterior aspects of the radial notch and surrounds the head of the radius, forming a ring. This arrangement allows the radius to rotate within the annular ligament and is important in allowing the forearm to undergo supination and pronation. The movements of supination and pronation also involve the distal radio-ulnar joint. This is a simpler joint with the rounded head of the ulna articulating with the ulnar notch on the medial side of the distal radius. Both of these radio-ulnar joints are surrounded by a joint capsule with a synovial membrane lining its inside. So contraction of pronator teres and pronator quadratus are going to rotate the head of the radius medially within the proximal radio-ulnar joint and also pull the distal head of the radius over the fixed ulna. This means the radius and the ulna are crossing one another within the forearm and the palm of the hand will face posteriorly. Activation of biceps brachii and also supinator will turn the palm anteriorly by rotating the head of the radius laterally so the radius and the ulna are parallel within the forearm. So let's just detail a couple of injuries that relate to this region. Firstly, dislocation of the elbow joint. The elbow joint dislocates most often in children posteriorly, when the elbow is flexed and they fall on their hands. This drives the ulna posteriorly and the humerus is forced through the anterior part of the joint capsule. This can cause damage to the ulnar nerve and can result in a loss of sensation from the medial 1.5 fingers and a weakness in flexing and abducting the wrist. Secondly, and occurring at the proximal radio-ulnar joint and also in young children, is subluxation of the radial head, also referred to as pulled elbow. This usually occurs when a child is pulled upwards suddenly and the proximal head of the radius is pulled out of the annular ligament. The head of the radius then jams the annular ligament against the capitulum, and this is what causes the severe pain. So to finish the podcast, I just want to mention briefly the wrist joint. The wrist joint is also known as the radiocarpal joint, and it's important to remember that the ulnar bone does not form part of the joint, with the radius and the articular disc of the radio-ulnar joint articulating with the proximal row of the carpal bones. The radiocarpal joint is covered by a fibrous capsule, which again has a synovial membrane lining its inside. There are 4 ligaments that aid the joint capsule in strengthening the joint. There are 2 radiocarpal joints, both the palmar and dorsal, with these extending from the radius to the carpal bones on both sides of the wrist, and also 2 collateral ligaments. The radial collateral extends from the styloid process of the radius to the scaphoid bone, whilst the ulnar collateral ligament extends from the styloid process of the ulna to the tricrectorum. So in this podcast, I've detailed the joints of the upper limb and also given some details about some common dislocations. In the next podcast, number 13, I will look at some more injuries involving the musculature and nerves of the upper limb.